with our chest X-ray learning, and I am sure you're all excited to learn. Tell me, excited to learn or angry? What do you think? है ना? So कई बार बच्चे आते हैं मेरे पास, they will say, sir इतना पढ़ाया मैं थक गया, है ना? So that is the beauty of it all is कि इतना पढ़ाया थक गया, तभी तो मजा आएगा. Okay, so now I am all set to do the class. Okay, so let us revise. Let us see what we have done so far. We started with chest X-ray, and I have made you aware on terms like pleural effusion, okay, empyema. Are you able to recall all that? Pneumothorax, okay. And not only that, we also learned about what is fast, E-fast, okay. And after that, if you remember, we learned about what is pneumomediastinum. Are you able to recall all that? Pneumomediastinum, continuous diaphragm sign, we saw the Nuclearius V sign. And after that, if you remember, we discussed things like, okay, we discussed things like consolidation, collapse, and I told you signs like Silhouette sign or Silhouette sign, and we also discussed about the air bronchogram. Okay, so this is approximately what we had done in the last class. And towards the end of the class, I discussed for interstitial lung disease, why we need, what is the role of HRCT, what do we mean by UIP versus what is NSIP. This is what we discussed in the last class. Everybody clear? Okay, आगे बढ़े? Okay, this is where we were, in the last class. Now today what I'll do is, I will show you some specific easy signs to look at, and there will be some named signs to understand on different diseases, some of which you might have studied in your microbiology class. I will just try to recap for you, and gradually after some specific diseases, I will go on to the chest CT. Okay, that is my plan for today. Let us understand the image that we are looking at. Okay, the first image that we are looking at. In this image, if you notice correctly, you are able to see a rounded opacity, which is appearing round. Okay, but if you notice and if you pay attention, you will be able to see around the opacity there is a dark rim. Around the opacity there is a air-filled rim. It seems to me that probably we have a air-filled cavity, and in that cavity you have a super added fungal colonization. Which fungus could this be? Which fungus could this be? Have you studied this so far? So in your microbiology, they will tell you that there is a fungus which is ubiquitous, which is aspergillus. So this is called as aspergilloma or fungal ball. So how do we identify this in the exam? Beta, this is the first page only. So every class I see, after 5 minutes, somebody will come and say, "Abhi कितने page हो गए?" And then they will say कि अभी कौन सा subject है? So beta, this is radiology going on, and we are looking at aspergilloma. The key to identifying is that in this fungal ball, around this fungal ball, you should be able to see a crescent of air. Okay, you should be able to see a crescent of air. This appearance has been called as air crescent sign, or it is called as the Monod sign. or it is labeled as the Monod sign, which is the, if I have both in the choice, the better answer to mark here is Monod sign. So in your exam, they will simply say Monod sign on a chest X-ray seen in. The answer is aspergilloma. Aspergilloma. Now let's see if you can answer better. Okay. Okay. Let's try to understand and answer. Okay. Suppose a patient is asthmatic or somebody has cystic fibrosis. Okay. Suppose a patient is asthmatic or has cystic fibrosis. These patients, okay, I will not repeat this sign, beta Janvi, otherwise you will make fun of Binod. Okay, I'm repeating. The sign is Monod sign. The sign is Monod sign. In a fungal ball, you will see a crescent of air surrounding it. That is called as Monod sign. This is not Binod. Okay. Now see. In asthmatic patients and in cystic fibrosis, very important, sometimes these people develop an allergic response to the aspergillus fungus, that is called as allergic bronchopulmonary aspergillosis. Have you heard of this so far? So in which kind of patients do we see ABPA? ABPA is seen in asthmatics and cystic fibrosis patients. Everybody clear? Okay. Now, how do we identify ABPA on a chest X-ray is very often asked in your exams. So let's see an answer. Suppose these are your lungs and these are your bronchi. Okay. If you have a allergic disorder, okay, everybody listen to me. If you have a allergic disorder, the bronchi will be full of mucus. Why? Because in allergy, there is hypersecretion of mucus. So in allergic bronchopulmonary aspergillosis, you develop mucus plugs in the bronchus. Okay. Some of the bronchi will develop mucus plug. Okay. Now listen to me and answer. Now these bronchi which are filled up with mucus, when you look at them on X-ray, they will appear opaque. They will appear white. Let me show you how they look like. Okay. Let me show you how they look like. Now please see, I am trying to zoom the image to the maximum. Can you see these mucus filled bronchi which are appearing white? So this white thing that you see here, the opaque thing, these are all mucus filled bronchi that you see in ABPA. Now, can you look at them with me and tell me how are they looking like? What is the appearance? Okay. So beta, we started at 10:05, just like I promised Deepti, so ghar pe ladai mat kara yaar. We started at 10:05, bilkul. Okay. Now please see this here. Okay. So this is called as the gloved finger appearance. This is called as the gloved finger appearance. Sometimes called as gloved finger of Simon appearance. Okay, so very, very important. Very, very important. I can see, can you see? It is so obvious. Agar aapne bhi dekha hota, you would have called it the same. So this is why it has been called as the gloved finger appearance. Okay, so in aspergilloma, we had Monod sign, but in ABPA, the answer that you have to mark in the exam is gloved finger appearance, or we might say gloved finger of Simon appearance. Now, when you have a long-standing ABPA, the bronchi are occluded by mucus plugs. So what happens is, because of obstruction, proximal to the mucus plugs, the bronchi, the central bronchi, they start to dilate. Can you imagine now? Suppose you have an obstruction, the area proximal to this obstruction will tend to get dilated. भाई जहां रास्ता बंद है उसके पीछे dilatation होनी शुरू हो जाएगी. So what happens is you will read this line in respiratory medicine also. In long-standing ABPA, the patients develop central bronchiectasis. In long-standing ABPA, the patient develop central bronchiectasis. Okay, now everybody know. So this is a previous exam question as well. Name a condition in which you have gloved finger appearance and central bronchiectasis. What is the answer? Allergic bronchopulmonary aspergillosis, ABPA. Okay, now let's see if you can answer. Now I will give you a question to solve. Let's see how many of you are able to solve my question. A patient underwent bone marrow transplant. Okay, very important question. I'm sure you might have studied the same in your microbiology also. Very important to remember. A patient underwent bone marrow transplant. Okay, so after bone marrow transplant, what happens? You become immunocompromised. You have neutropenia. And we know from our experience already that Aspergillus is a ubiquitous fungi. It is present everywhere. So now what will happen, beta? Now, if you are immunocompromised, you don't have neutrophils. Now what will happen is you become more predisposed to develop Aspergillus infection. So if I draw a CT scan of the chest, okay, if I draw a CT scan of the lungs, these patients will develop a consolidation due to Aspergillus infection. Not only that, these patients will also develop surrounding hemorrhage. These patients will have a central consolidation with surrounding hemorrhage. Okay, this is called as angio-invasive aspergillosis. Everybody clear? Okay, so now do you understand? Beta, वो cavity तो थी. Cavity हो सकता है. In the first image we saw a cavity that was probably because of old tubercular infection. है ना? But now what you have inside the cavity is a fungal ball. Everybody understands? Now let's see if you can answer. So the question is, the same Aspergillus that we learned earlier, if the patient has a history of bone marrow transplant and the patient is immunocompromised, now develops angio-invasive aspergillosis. This appearance on a CT scan is called as halo sign. Why do we call it halo sign? Because you have central consolidation and surrounding hemorrhage. Center में consolidation है और आसपास hemorrhage है. Let's see if some of you can answer. Why do you have surrounding hemorrhage in this infection? Yes, this is a CT scan. Yes, correct. I've labeled it also. But can you tell me, beta ji? Can you tell me, beta ji, why you have surrounding hemorrhage? Why? Because this fungus is, what did I write? Angio-invasive. Now this Aspergillus fungus in an immunocompromised patient invades the blood vessels. It goes into the blood vessels and causes surrounding hemorrhage. Now I want to clarify here. There is a sign which is called as reverse halo sign. Okay, that is different. Okay, if we have, very important to understand, if we have a central halo and peripheral consolidation, so in the center we have ground glass haze, ground glass opacity, periphery we have consolidation, that is called as reversed halo, also known as atoll sign. That is what you are hearing nowadays in COVID-19 pneumonia. It is a feature of organizing pneumonias. Also seen in collagen disorders, collagen vascular disorder, but or rheumatological disorders, we'll say cryptogenic organizing pneumonia. Okay, so I hope somebody was saying COVID. Now you get it. In COVID, we don't say halo sign, we say reversed halo sign. It will be asked in your exam and you might get it wrong. That's why I'm clarifying it here. Reversed halo is also called as atoll sign. I'm sure you might have seen the video that I did on COVID radiology. It is a good idea to please look at that video. And because I feel, it might be an important concern in future. So it is important, even as a doctor, to know all this today. Clear? So the best answer to mark for halo sign is angioinvasive aspergillosis. And for reversed halo sign, the answer is cryptogenic organizing pneumonia. This is what I would mark earlier, but in 2020, we also include COVID-19 as one of the causes. So we know now that COVID-19 infection initially would have ground glass appearances, then it might progress to consolidations and even to organizing pneumonias, which will lead to reversed halo or atoll sign. Everybody understands? Okay, very good. Now, so some of you are thinking that why is sir suddenly telling three things? Actually, I have told you only one thing so far. I have told you what is the radiological appearance in aspergillus. A patient with old tubercular cavity can develop a fungal ball, and the appearance was, what did I teach you? Monod sign. Okay. Even in DM entrance, they ask these questions. So very important. Second, very important to know, in patients who are asthmatics or with cystic fibrosis, what can they develop? What did I teach you? These people with aspergillus antigen will develop ABPA, allergic bronchopulmonary aspergillosis, where we learned these signs like gloved finger and central bronchiectasis. But if the patient has immunocompromised state, then the aspergillus becomes more invasive. It becomes angioinvasive aspergillosis, and I taught you a sign called as halo sign. Okay, so this is where sometimes children, they get confused. Okay, sometimes people get confused here. Okay, बेटा डीएम एंट्रेंस में नहीं पढ़ना, यहीं पे पढ़ेगा, एमडी में नहीं पढ़ेगा, वो यहाँ से याद आएगा तेरे को वहां पे. Okay, so this was asked in DM infectious disease entrance exam recently, and many people could recall from their PG entrance classes with us, and they send me a message. That is why I know. Okay, clear, beta? Everybody? Okay, very good. Now, once you understand all this, let's go back. Let's go back and go back to the images. So we have only learned two images so far, and the common factor in these two images was aspergillus. So we will make a flashcard. Now the flashcard is like this: aspergillus. Everybody understands? Okay. Now let's see the next picture. Now, what do you see in the next pathological image? Again, you might have seen the same image in your microbiology class. These are cysts. These are membranes. Okay. Are you aware of any infective cyst which is having multiple membranes? Now, cyst matlab it is with water. And water, listen to me, water in Latin is called as hydra. Hydra. So कैसे लिखेंगे बेटा? Hydra. Hydra. Hydatid. So the image is actually showing you hydatid cysts. What we are able to see? Hydatid cyst. So we need to learn how to identify hydatid in a radiological image in the exam. Okay. Let's see if you can answer. Investigation of choice for hydatid cyst. Investigation of choice for a hepatic hydatid cyst is. Okay, let's see how many of you are able to answer my question. Investigation of choice for hydatid is. Investigation of choice for hepatic hydatid is. For hydatid, the IOC is contrast enhanced CT, but if they mention hydatid in the liver, then I'm happy to go even with an ultrasound. I'm able to see it on an ultrasound. Many people they get confused in this question. Let's see how many of you can tell me when I say hydatid, which part of the body can have a hydatid cyst? When I say hydatid, it can be anywhere in the body. Hydatid can be in the brain, hydatid can be in the bone, can be in the heart, can be in the muscle. Hydatid can go to any part of your body. It can go to the spleen. It can go anywhere. So that is why CT would be a better choice when they say only hydatid. But if they say hydatid in the liver, which is the more common location, then you should mark ultrasound as the answer. So there should be no controversy here. But sometimes people get confused that why the two answers are there. Okay, the reason is this is why. Everybody understands? Very good. I can see all of you are so smart about all these infections. My question, second number is, how will we identify hydatid on an ultrasound or a CT? Hydatid initially, when it comes into the body, is viable, is alive, and on ultrasound, it is seen as a unilocular cystic lesion. Okay, so hydatid can be seen on an ultrasound as a unilocular cystic lesion. Then what happens is hydatid cyst has brood capsules, scoliosis. Have you heard of them? These brood capsules and scoliosis, they start floating in the fluid in the hydatid. So when I do an ultrasound, listen to me, these brood capsules and scoliosis, they look like sand. So when I do an ultrasound, these brood capsules and scoliosis, which are floating in the cyst, they look like hydatid sand. So that is what has been labeled in ultrasound as hydatid sand. Okay. Then the hydatid then starts to divide into daughter cysts, and inside the hydatid you can see multiple daughter cysts like this. You can see a multilocular appearance. Okay, then these are all three of them are viable stages. Then The hydatid has an inner layer called as endocyst. So in unfavorable environments, the endocyst detaches from the rest of the cyst. The inner layer is endocyst. The endocyst detaches. This is called as the transitional stage. And then it may become, when it dies, then it comes the dead stage. When it dies, we give respect to the dead, and we, even if he is an enemy, we will put some calcium on it. It becomes calcified, but not in every part. We will tell you where it does not calcify, but when the hydatid dies, it becomes calcified. Everybody understands? So hydatid can appear unilocular, can appear like a cyst with sand, can appear multilocular. You can see the endocyst membrane floating inside, or it can appear calcified. Okay, this is the background information that I want you to have. Now I want you to see the image with me. Let us see an ultrasound image together, and let's see if you are able to tell me the finding. This is the ultrasound of the liver, and this is your disease. Okay, this is the ultrasound of the liver, and endocyst is the germinal layer, beta. It is the germinal layer, so it detaches. Okay, that is. So anybody, can you tell me what do you see here? So this appearance looks like this. What is this? This is a cartwheel. This is classic appearance of hydatid cyst. This is how a multilocular cyst looks like, and this is what is called as cartwheel appearance on ultrasound. This is called as cartwheel appearance on ultrasound. Now don't get confused here. If they say cogwheel or wheel within a wheel, have you heard of them before? Can you name a condition in which in your surgery class or parasito or fungal or any micro class they might have talked about this? So cogwheel appearance is seen actually in hepatic candidiasis. Okay, everybody remembers? So many people get confused, so I'm trying to put the confusing things together. If they say cartwheel appearance on ultrasound, I will mark hydatid. But if they say cogwheel, wheel within wheel, bullseye, all those things, I will say hepatic candidiasis. Okay, liver candidiasis. Very good. I can see some of you are able to answer it correctly. Very smart. Okay, so it's such a pleasure to teach so intelligent students that you people are. It has been my pleasure to teach all of you. It is very interesting all the time to have constant feedback from you whenever you are answering. It is such a pleasure. So let's see the next picture. The next image is a CT scan image, which was asked 2 years back in the NEET exam. This is your liver. They said identify the disease. This is spleen, vertebra. I want you to look at the image and tell me where is the, okay, listen to me and answer. Where is the disease located? Which organ? Which organ is diseased? The answer is liver. Okay, it is the liver which is diseased. Do you have one disease or multiple disease? We have multiple disease. This is the liver, this is the liver disease, this is the disease. So you have multiple cystic lesions in the liver. But are these only cysts? Are these cystic lesions, or do you see something inside? We see the endocyst has detached and it is crumpled inside like this. This is called as crumpled membrane appearance, or we might call it as serpent sign of hydatid. Some of you are getting confused कि सर serpent कहाँ है? बेटा देखें, डरना नहीं बेटा, बाहर नहीं आएगा. Okay. Now tell me. So that is why we have used the words like crumpled membrane sign or serpent sign seen in hydatid. Everybody understands? So again, the answer here is hydatid. It is very simple. If you see a cystic lesion with a central floating membrane, it should make you think of hydatid. So in the exam, the question was simple. Patient has abdominal pain of vague nature. CT scan is shown to you. What is the disorder dealing with? The answer is hydatid. Very good. Now see the next picture. Again, this is a previous NEET image. These are images which have been as it is asked from your workbook in the exam. This is liver. This is spleen. The structure that you see here is your stomach on a CT scan. This is your aorta. Okay. Everybody clear? My question is, okay, beta, this is always the right side, this is always the left side. CT में हमेशा उल्टा हो जाता है, जो आपका हाथ राइट है वो दूसरी तरफ पे राइट होगा. बेटा don't get confused. Okay. Now any one of you can answer. So I hope आप liver, spleen, stomach ये सब देख पा रहे हैं. I want you to look at the aorta and tell me, do you see any dye in the aorta? No. There is no dye, no contrast given. That means this is a plain CT. This is a non-contrast CT. Okay. Now tell me, what is this? Can you see a white lesion in the liver? How white? As white as the bone. This is a calcified hydatid cyst. This is how a calcified hydatid cyst looks like. Okay, everybody understands? Okay. In the previous image, we can use both the terms. You can call it crumpled membrane, जैसा श्रद्धा है वैसे नाम रख सकते हैं आप. You can call it crumpled membrane, you can call it serpent. Okay, beta, somebody was asking. Now, are you clear with this? So the problem here is, now see with me an answer. Now, the only thing that I wanted you to understand is the hydatid can have multiple appearances depending on the stage of the disease. So the problem is, if you mug up कि hydatid white दिखेगा, black दिखेगा, then you will get it wrong. It depends on the stage. In the cystic stage, it will look darker than the liver. In the calcified stage, it will look more white. So instead of mugging up, we need to see the see the image and understand. And now, suppose, let's see an answer. Some of you are still getting confused. Suppose in aorta you had dye. Now, suppose you notice now, I have now made in the aorta dye. So that means then it would be contrast image. So in contrast, then the white thing that you see in liver could also be dye uptake. That is why it is important that we look for calcification in a non-contrast study. डाई देने के बाद तो डाई भी सफेद दिखेगी, तो हम कैसे बताएंगे कि ये कॉन्ट्रास्ट अपटेक है कि कैल्सिफिकेशन है? That is why it is important that we are looking at a non-contrast CT. That is why this word was important in the exam. And you can now guess that people who got this question wrong in the exam, they thought this could be a hepatocellular cancer or is tarah se, they did it wrong. Later on, gradually in my class, I will teach you how to identify liver cancer also, don't worry. But so far, I want you to just see hydatid. Okay, now my question is, let's see if you can answer. Let's look at one more image together. Okay, this is your liver. Let's see, better you have to diagnose this. These are your lungs. Okay, focus. Anybody who diagnose this will get a chocolate also, beta. This is left ventricle, right ventricle, right atrium, IVC, aorta. Okay. How do I know all this? I will teach you, beta. I will teach you how to identify. Listen to me. I will teach you. Okay. Okay. Listen to me. Listen to me. बेटा वो कैल्सिफाइड था ना, इसलिए वो दिख रहा था. अभी बेटा मैं बताऊंगा बेटा. Everybody listen to me. Don't run. I will tell you everything. Now, how do we know which cardiac chamber is this? So the cardiac chamber which has the thickest walls is the left ventricle. The cardiac chamber which is right behind the sternum is right ventricle. वो सबसे आगे है ना, right ventricle. And we can see the right atrium and the IVC draining into it. Can you, any of you smart children, identify, can you see this structure, tubular structure opening into the right atrium? ये क्या हो सकता है? This is your coronary sinus. Did they teach you in anatomy that there is a venous structure called as the coronary sinus draining into the right atrium? यहाँ पे वो है ना, वो coronary sinus है. Now let's see an answer. I am looking at a disease in the right lobe of liver in the superior segments of the right lobe. Okay. Now tell me, is this disease as black as the air? No. Is it as white as the bone? No. It has a color in between black and white. We know it by now. This must be fluid. Okay. This must be fluid. Now tell me, okay, now tell me, is this a fluid containing hydrated cyst? क्या ये hydrated cyst है? The answer is no. Why not? I'll tell you why. Can you see surrounding this fluid, there is a enhancing wall. There is a wall which is taking up the dye. This must be a rim of inflammation. A rim of inflammation taking up the dye. And if you notice, surrounding that wall, you have a rim of edema. पस दिख रही है, उसके आसपास एक वॉल है जो एनहांस हो रही है, and then you have edema surrounding it. Okay, that tells me that this liquid that we have has an inflamed margin जो डाई का अपटेक कर रहा है, वहां इन्फ्लामेशन है, and that is having hyperemia. And not only do you have an inflamed capsule, you also have surrounding edema. ठीक है. सेंटर में, दैट मीन्स सेंटर में जो लिक्विड है वो पस है, देन यू हैव अ कैप्सूल ऑफ इन्फ्लेमेशन, देन यू हैव सराउंडिंग edema. This is why now I will label it as amoebic liver abscess. This is not hydrated. Hydrated में, surrounding the hydrated, you will not have, listen to me, hydrated में, surrounding the hydrated, you will not have edema, you will not have inflammation, because remember, hydrated जब तक membrane intact होती है, the membrane does not allow any immune response to happen. Remember microbiology में बताया था उन्होंने कि when you are operating on hydrated, the hydrated should be removed in total. If you spill it, it will lead to immune response. Okay, so that is the key. This is how you identify that, because I am able to see a lot of evidence of inflammation around the liquid containing area, then I will call it as an abscess. Okay, my question is, why amoebic? What are other causes of abscesses? Abscess in the liver can be pyogenic. So amoebic liver abscess is usually a single large abscess in the right lobe of liver. Pyogenic abscesses are usually multiple in both lobes of liver. Okay, how this is CECT beta? Okay, some of you are getting confused. Look at the heart. Can you see the cardiac chambers are appearing white because they have dye inside them? उसमें dye है ना बेटा? Can you see that? Why is the cardiac chambers appearing white? Because of the contrast material. Okay, now let's see. Okay, and anybody can answer beta. Gradually you can answer. So why this was amoebic abscess? Because we saw a single large abscess on the right side. Pyogenic abscesses are multiple and they're present in both lobes. Okay, now let's see if you can answer beta. Any one of you can answer. The question is, why is amoebic liver abscess more common on right side? Amoebic abscess right lobe of liver में क्यों जाती है? Okay, let's see an answer. Suppose this is your ascending colon. This must be your cecum. Okay, this must be your cecum. Amoebiasis, when it involves the cecum, we call it as amoebic टिफिलाइटिस. टिफिलाइटिस मतलब सीकम की इन्फ्लामेशन, सीकम की सूजन. Now what happens is the amoeba from the cecum can go into a vein called as superior mesenteric vein. This amoeba from the cecum can go into the superior mesenteric vein. The superior mesenteric vein joins a vein coming from left here, which is the splenic vein, and it joins to form a large vein called as the portal vein, and portal vein is going to go into the liver. Okay, now what happens is, because portal vein is a large blood vessel, the amoebae which are climbing from the superior mesenteric vein, they tend to remain into one side of the portal vein, and this side goes into the right side, and the blood coming from the splenic vein tends to go towards the left side. Okay, everybody understands? Are you clear? Are you clear or not? That it is the superior mesenteric vein through which the amoebae are going into the portal vein, and the blood from superior mesenteric vein in the portal vein tends to go to the right side more than the left side, while the blood from the splenic vein tends to go more towards the left side. Okay, so this is how in physiology the portal vein distribution is. This is because of the laminar flow that happens in the portal vein, and this is the reason why you have amoebic liver abscess more common on the right side. On the other hand, pyogenic liver abscesses are seen in people with bacteremia. Okay, pyogenic liver abscess दिखेगी उन लोगों में जिनके ब्लड में बैक्टीरिया है. So if it is in the blood, if there is a bacteremia happening, then it is likely that it will go to both lobes of liver. And because you have bacteremia, this patient will be more toxic. Okay, amoebic abscesses, usually the patient will not be that sick. So what happens is, this patient is more toxic, and abscesses are usually small in size, multiple, and at those small size of abscess itself, the patient comes to the doctor. In amoebic abscesses, the abscess tends to grow larger because the patient is not as sick as you have in a pyogenic abscess. Everybody understands the concept? Okay, so this is the why behind it. But the key is, they will not ask you why. Why is for your own comfort. The exams, they don't like, the patient will never ask you why. Do you understand? Patient will ask you, what is the treatment of my disease? He will not ask you why, क्यों हो रहा है, कैसे हो रहा है, वो थोड़ी पूछेगा. ये तो आपको जानना है as a doctor. So that is why the exams will not ask you the why. They will ask you, what do you think this is? This is amoebic liver abscess. And the choices will say hydatid cyst also. Please do not mark hydatid, because you can see pus liquid in the center, then a capsule, then edema in the surrounding parenchyma, telling you that there is inflammation in the liver. Everybody clear? Everybody understands the concept? Okay, very good. Now let's see. My question now is, can you have hydrated in the lungs? We were studying the chest x-ray, so we need to come back to the lungs. Do you have pulmonary hydrated? So now remember, hydrated in the lungs grows large size and does not calcify. Okay, hydrated in the lungs grows larger and it does not calcify. Can you guess the reason why? The reason is that in lungs there is no obstacle to growth of hydrated, because the lung parenchyma is all air filled thin structures. The environment is very favorable for hydrated to grow. Let's try to understand. Better, let's try to understand. In liver, if the hydrated wants to grow in liver, the organ is stiff. The liver is a stiff organ. It does not allow it to freely grow. While in lungs, it is easy to stretch and grow because it is all thin walls of parenchyma. So hydrated tends to grow larger, and because it is growing, it is unlikely that it will die soon. So it does not usually calcify. Everybody understands? Okay. So now please understand and answer. Now let's understand a picture. Then I will show you the picture on X-ray. Hydrated has outer layers and it has inner layer. And you know the innermost layer is the germinal layer, which is called as the endocyst. Let's see if you can answer my question. If in hydrated, okay, if in hydrated the endocyst ruptures, okay, if in hydrated the endocyst ruptures, what will happen? The cyst which had fluid or water would settle down. The water will settle down. The fluid always settles down. And the daughter cyst that you have in the hydrated will float. This is what has been called as the water lily. The water lily flower is also called as the camelot sign on chest X-ray. Okay, this is called as water lily or camelot sign on chest X-ray. Okay, everybody understands? So I'm teaching very slowly, so sometimes you might be thinking that it is going paused. No, I think it's not paused. Everybody clear? Okay, now let's identify this previous question from the exam. Can you find the problem on this chest X-ray? This is the right side. This is the disease. Okay, let's see how many of you are able to diagnose it. So do you see in this disease, there is some water, because we can see a air fluid level. And not only do you have water, okay, if you pay attention, you will be able to see above the water, you can see the daughter cysts are floating. This is called as the water lily. The water lily flower is also called as camelot, है ना? मेहमान सर, वो water lily flower का ही दूसरा नाम है camelot. So इसे camelot sign. So these are the daughter cysts which are floating. Because the endocyst has ruptured, we will call it camelot sign, or we will call it hydrated, the water lily sign. This is the diagram to understand. So why do we see a water lily sign on chest X-ray in hydrated? It happens because of the endocyst ruptures. If the endocyst ruptures, this gives rise to such appearance. Okay, everybody understands? Okay, now I know you have some questions, but don't worry, I will answer your questions. Don't worry, I will show you, because you have to wait. I will show you. So beta, these are the beta invisible नहीं है, थोड़ा सा कोशिश करेंगे. Okay, now see. Can you see जहां पे पानी के कारण फ्लूइड लेवल बना, ये है, उसके ऊपर कुछ तैर रहा है ये. This is called as the water lily appearance. Okay, everybody understands? Okay, now let's see an answer. But beta, the only thing I want all of you to remember is every lily is not hydrated. Every lily is not hydrated. Okay, remember एक और लिली आपको सर्जरी में यूरोलॉजी की क्लास में बताई. If any of you remembers, you might have studied this in surgery, which is called as the drooping lily. So हर लिली hydrated नहीं होती. एक साइन है drooping lily sign on IVP. Anybody remembers? Anybody? So then उसको वाटर लिली नहीं कहना बेटा, इसका नाम है ड्रूपिंग लिली. वाटर लिली तो हाइड्रेटेड वाला था ना, ये दूसरा लिली आ गया बेटा, दूसरा फ्लावर है, गलती हो जाएगी. Drooping lily sign on IVP is seen in duplication. Did you study this in your surgery class? Drooping lily sign on IVP. IVP होता है intravenous pyelogram. Don't worry, I will teach you that also. In duplication. Now try and understand. I will show you. Beta, listen to me. I will tell you the reason. Duplication मतलब होता है, suppose from one kidney you have two ureters. Upper pole ureter, lower pole ureter. What will we call it? Duplication. So in duplication, upper pole ureter is more likely because of anatomy. Okay, upper pole ureter, because of its anatomy, is more likely to show obstruction. Okay, कौन से पोल पे ऑब्स्ट्रक्शन ज्यादातर दिखेगा? अपर पोल यूरेटर में. सो अपर पोल यूरेटर्स टेंड टू ओपन लोअर एंड दे आर मोर लाइकली टू बी ऑब्स्ट्रक्टेड. अगर यूरेटर ऑब्स्ट्रक्ट हो गया, सो व्हाट विल डेवलप इन द अपर पोल? Hydronephrosis. So if I now tell you, in duplication, the upper pole tends to get hydronephrotic. Okay. अगर बहुत ज्यादा hydronephrosis होगा, so if it is a severe hydronephrosis, what will happen to the cortex of the kidney? The cortex of the upper pole will become paper thin. It will be as thin as a paper, useless. Now when we give dye to the patient, when we give intravenous dye to the patient, the dye is only taken up by the lower pole parenchyma, then excreted into the lower pole pelvis and calyces, and into the lower pole ureter. This lower pole ureter is pushed down by the upper pole hydronephrosis. You will not be able to see the upper pole because that is a paper thin cortex. It is not taking up the dye. This is called as drooping lily. Drooping lily sign is seen in duplication because in duplication the upper pole tends to develop obstruction. It becomes hydronephrotic and the cortex becomes paper thin. Everybody understands the rationale and the logic behind it? Now please see an answer. This is your ureter, and these are your lower pole calyces giving rise to a drooping lily appearance. What is the cause? Duplication. Okay. Although we see only one ureter, we still are calling it duplication because we can see that the lower pole is drooping down. So that means there must be something above it which is pushing it down. So you have a hydronephrotic upper pole which is not visible because the cortex is not functional, but it is pushing down the calyces to make it appear like a drooping lily. Everybody understands? So the entire moral of the story is there are two type of lilies. There is a water lily flower, also called as the camelot, and there is a drooping lily flower. ओके सो हर लिली हाइड्रेटेड नहीं होगी, ध्यान से देखना है कौन सी पूछी है, ठीक है. वाटर लिली हाइड्रेटेड, ड्रूपिंग लिली डुप्लीकेशन. Okay, don't worry if you don't know IVP so far. I will show you IVP signs also in due course, and then I'll explain how it is happening. Here my goal was only to make a flashcard on lilies. Okay, these are lilies in medicine. Okay, so once you're clear, everybody clear? Okay, now let's go further. Now I will show you some more appearances which have a characteristic appearance. This is a CT scan of the chest, CT scan of the lungs. I want you to look at the bronchi, and I want you to look at the walls of the bronchus. Okay, I'm zooming it, beta. I'm zooming it. Okay, I'm zooming it. Do you think in the image that I am showing you, do you think the bronchial walls are parallel to each other? Do you think in the image that I am showing you, the bronchial walls are parallel to each other? Yes. So if they are parallel, what should I call them? So you know by now, if there are two parallel lines, they always call it tram track appearance, or I will use a word, railroad appearance. Okay. Okay. But the key here is a normal bronchus is supposed to taper. नॉर्मल ब्रोंकस तो सेंटर से पेरिफेरी तक टेपर होना चाहिए. Normal bronchus should taper from center to periphery. Here it is appearing parallel. That means it is dilated. So if the bronchus is dilated irreversibly, we call it bronchiectasis. Okay. Now see, so in the exam they might say tram track appearance on CT chest, bronchiectasis. Okay. Any one of you can tell me now tram track appearance on skull X-ray. Tram track appearance on skull X-ray. Anyone? Was Sturge-Weber syndrome. Remember we discussed in the last class Sturge-Weber syndrome. And let's see if you remember. Tram track appearance in optic nerve. Anybody can tell me from ophthalmology class. Tram track appearance in optic nerve. Anybody? You remember ophtha teacher was telling you, I saw that in that lecture also. Tram track appearance in optic nerve is optic nerve sheath meningioma. Okay, so glioma will not have tram track appearance, hai na? So that is how you differentiate between an optic nerve glioma and a meningioma. Tram track appearance in optic nerve is optic nerve sheath meningioma. Tram track appearance on a CT scan is of the chest is bronchiectasis. Now I want you to understand again, this is your bronchus and this is a accompanying vessel. In a normal person, bronchus and accompanying vessel should be of same diameter. In bronchiectasis, the bronchus dilates and the vessel is of same size as before. Hence, in bronchiectasis, we use a term called as signet ring sign on CT. Okay, so this is what is called as signet ring sign on CT. Okay, so depend कर रहा है बेटा, ध्यान से देखेंगे. A bronchus which is cut longitudinally, जो bronchus लंबाई में कट रहा है, वो अगर dilated है तो it is looking like a tram track, and the bronchus which is cut in a transverse axis, if it is dilated, it will look like a signet ring. So both tram track and signet ring are signs of bronchiectasis. Okay, now let's see if you can answer. Okay, so Sarthak has asked us a question about why optic nerve meningioma. Let's see an answer. बेटा अगर suppose ये globe है, ये optic nerve है, and these are your extraocular muscles. Okay, so meningioma in the optic nerve sheath arises from the nerve sheath. So what happens is the tumor is present like this. इधर पे भी होता है, इधर पे भी होता है, cross section में ना. If you have a tumor around the nerve, it is not the tumor of the nerve, it is the tumor of the nerve sheath. Meninges का tumor, meningioma है. So then if you cut it, you see tumor on either side of the nerve. That is why in optic nerve sheath meningiomas we call it tram track appearance. Clear? Okay beta, I think now you are clear. And I will ask you now a integrated question to answer. Suppose I say a patient has bronchiectasis with sinusitis with situs inversus with infertility. What will you mark as the answer? Suppose I say bronchiectasis with sinusitis with situs inversus infertility, then you will mark Carter-Jenner syndrome. Okay, and suppose they say bilateral upper lobe bronchiectasis in the lung on a CT scan, plus the patient has pancreatic insufficiency, then what will you think of? तब क्या सोचोगे? Okay, then you think of cystic fibrosis. So bronchiectasis with pancreatic insufficiency, we are trying to build an integrated question on cystic fibrosis. Okay, very intelligent students. I already told you that you people are the most intelligent students that we have seen so far. And Dr. Deepthi is smiling at me, sitting there, that she's already experienced. Because it is such a pleasure to teach you, in the afternoon when Deepthi is teaching, I am listening to whatever she is teaching, and when I am teaching, she is there. So it is such a gesture by our schedulers that have made the schedule like this and put us together. It's clear? Are you able to mark all this? Very good, very good. So this is how the visual would look like. All you need to do in the exam is identify cystic fibrosis by looking for bronchiectasis. Bronchiectasis will be the thing that they will show you in the CT if they are talking about cystic fibrosis or if they are talking about, tell me, carcinogenesis syndrome. But the key is the words tram track appearance and signet ring sign. Are you able to mark it? Very good. Now let's see if you can answer a question. Let's see if you can answer a question. Okay, let's see. The question is, suppose you develop an infection in the lung. Okay, suppose we develop an infection in the lung. You need to tell me the infection that I'm trying to talk about. Suppose you develop an infection in the lung, and that infection leads to some inflammation surrounding it, and then the central part undergoes necrosis and damage happening here because of inflammation. There is damage. What will happen? You will see a ring-like area of inflammation that is called as cavitation. Now imagine now, this is how it would look like. Suppose I make it for you, try and see it with me. Can you see this ring-like white thing where you have some inflammatory soft tissue? This is called as cavity. As soon as I say cavity, any one of you, as soon as I say cavity, which disease comes to your mind? The answer is tuberculosis. Very good. Answer is tuberculosis. Let's see if you can answer. My question is, if any one of you can answer, बच्चे बताएं, प्राइमरी टीबी के सेकेंडरी cavitation is more common in प्राइमरी की सेकेंडरी बताओ. Cavitation is more common in secondary tuberculosis. अच्छा, एक बात और बता दो. If a AIDS patient develops tuberculosis, will you see cavitation? भाई कैविटेशन तो तब थी ना जब इन्फ्लामेशन हो रही थी चारों तरफ. इन्फ्लामेशन के लिए हमें इम्यून रिस्पॉन्स चाहिए. ओके, so if in AIDS you develop tuberculosis, cavitation is unlikely. If in AIDS you develop tuberculosis, cavitation is unlikely. Cavitation is a classic feature of secondary TB because you need an immune response to demonstrate cavitation. Everybody understands? Very good. Now tell me, name any other disease that you know of which can show cavitation. The question is, can a neoplasm show cavitation? Can you have a neoplasm showing cavitation? The answer is yes. Which neoplasm? The answer is squamous cell cancer of the lung. So in the exam, they will often ask you this question: which lung cancer shows a cavitating mass? The answer is squamous cell cancer of the lung. And cavitation can be seen in, you may have bilateral cavitations in systemic disorders like, did you read this in ENT? Wegener's granulomatosis. Okay, so everybody clear? Okay, everybody understands? So cavity can be seen in tuberculosis, which is characteristic, but can be a neoplastic cavity, can be a systemic disorder like Wegener's granulomatosis, and even if you have septic emboli in the lung, you might see cavitating nodules. Very good. Now my question is this: suppose you have a disease which leads to inflammatory ring in the lungs, But in the center of that ring, now you have some liquid developing, some pus developing because of the dead RBC, dead WBCs and dead bacteria. What do you think? है ना? Bacteria भी मर गए, WBC भी मर गए. What is this? Pus. So then you will call it as lung abscess. It is difficult to differentiate between a cavity and an abscess, but the most important feature of abscess is that in the center you should have liquid, you should have pus. So if you have pus, you should see, what do you see here? Air fluid level. Okay, so in the lung abscess, you will see air fluid level. But in hydatid, remember on the air fluid level, then we saw the daughters floating. Then we called it water lily. So this is how a lung abscess would look like. It would look just like a cavity, but you will see a air fluid level. A clear-cut, well-defined air fluid level, then we call it as lung abscess. Are you clear? So now if you notice, I will show you a symmetry. I have talked about abscesses so far in 3 parts of the body. I have talked about abscess in the brain when I told you उसमें pus होगी, thick होगी, diffusion पे bright होगा. Remember brain abscess? Then I talked about abscess in the liver where I showed you amoebic abscess and pyogenic abscess differentiation. Now I am showing you lung abscess. Anywhere in the body, if you have a pus collection, it is called as abscess. So this is how it looks like. Okay, very good. Now once you are clear, let's see if you can answer. Okay, I'm about to come to a very, very important X-ray. Okay, very often asked. Okay, a very, very important X-ray that I'm going to show you now. This X-ray has multiple nodule looking like millet seeds. इस एक्सरे पे बहुत सारे छोटे छोटे नोड्यूल हैं जैसे मक्के के दाने हो. दिस इज कॉल्ड एज मिलियरी mottling on a chest X-ray, typically seen in tuberculosis, due to hematogenous dissemination. Clear? अगर टीबी हेमाटोजेनस डिसेमिनेशन हो जाए then we call it as miliary TB. Miliary माने millet seed. Millet मतलब मक्के के दाने के जैसा दिख रहा है miliary. Okay. Now let's see how many of you can answer this question now. This is the background information that you have. Okay. Now I want you to answer a question. A patient in America recently went into a cave for a tourist. As a tourist, he went to visit some caves, developed fever, chest X-ray shows miliary appearance. Then what is your cause? So this is how the questions change when you go to USMLE exams. They will ask you questions about diseases which are prevalent in America. Anybody? A patient goes to America, visits caves as a part of his touristic activity, develops fever, X-ray chest is showing miliary. Then you will say that he has developed acute onset histoplasmosis. है ना? तो रट के नहीं जाना कि मिलियरी है तो टीबी ही होगा, ऐसा नहीं है. It could even be histoplasmosis. Are you clear? So histoplasmosis, the key word to remember is because of exposure to bats, and bats lives in caves, especially in America Midwest. So the answer here is histoplasmosis. I can see most of you are able to answer. That's why I said you people are so smart. Can you name any other cause of miliary appearance? Can you name any other cause of miliary appearance? Varicella. Varicella, chickenpox, when it affects the lung, can also lead to such appearance. Okay, let's see. Any other query you have? Any other cause of miliary appearance? So miliary appearance can also be seen in things like sarcoidosis, silicosis, cold worker pneumoconiosis, hemosiderosis, which happens due to long-standing mitral stenosis. Rare cause, but it is possible. Long-standing mitral stenosis will lead to pulmonary venous hypertension, and which will lead to hemosiderin deposition in the lung, which can also look like miliary appearance. And don't forget, even metastasis can look like miliary appearance. Later on in gynae, you will read about a malignancy called as choriocarcinoma. Choriocarcinoma, when it goes to the lung, looks like miliary, and we call it as snowstorm appearance on chest X-ray. So not always it is infective. Even metastasis can look like miliary appearance, especially from choriocarcinoma, where we use a word snowstorm appearance. So always remember TB, but don't forget histoplasma, varicella, sarcoid, silicosis, metastasis, and hemosiderosis as causes. Okay, very good. So what happens is in the exams, they often try to trick you by showing you miliary appearance, but the answer would be something else other than TB. So that is a common trick used in the exams. So suppose I ask you, miliary appearance in TB is seen due to hematogenous spread. जब blood के अंदर बीमारी फैल गई तो we are able to see multiple nodules there. Now I want you to look at another X-ray and differentiate. I want you to look at another X-ray and differentiate. Any one of you? Any one of you, can you pick it up? Now again you have multiple nodules in the lung, but these are larger in size. ये मक्के के दाने के जितने बड़े नहीं, उससे ज्यादा बड़े. कितने बड़े? So now these nodules are larger. These are as big as the cannonballs. So we call it cannonball appearance, seen in lung metastasis. This is what is called as cannonball appearance. So how will you differentiate, beta? Size है ना, देख ये cannonball बड़ी है, मक्के के दाने वाले छोटे थे. So we are able to differentiate. Are you clear? Okay, so both of them are hematogenous. That is why I am keeping them together. That TB, when it spreads via hematogenous route, looks like miliary appearance, millet seeds, while cancer, when it spreads via hematogenous route, looks like cannonball. So this is typical cannonball appearance seen in lung metastasis. Okay, now initially it was described for RCC, but now we believe that all cancers can have this appearance. My question is, this is a NEET 2019 question. Let's see how many of you are able to answer this question. 30-year-old male has hemoptysis, chest X-ray is shown to you. The cause of hemoptysis is TB, histoplasmosis, testicular cancer. And the X-ray shown in the image was this. Okay. The X-ray shown was this. So what do you see in this X-ray? Cannonball appearance. 30-year-old male. Now in 30-year-old age, in a male, if you see a X-ray suggesting of metastasis, not many cancers occur in young. So we have to think of cancers like testicular tumors, which are problems of young males. Do you remember? So the answer was testicular malignancy. But many children after the exam were unable to understand कि सर चेस्ट एक्सरे में टेस्टिकुलर ट्यूमर कैसे पता चल गया. But what they could not understand is वो मेट्स दिख रहे थे young male में. There are not many causes of lung metastasis in a young male. Testicular cancer should be on top of the differential diagnosis. Are you clear? Okay. Another question I want you to answer is, name a tumor which is seen in a child which is known to cause lung metastasis. Name a tumor which is seen in a child which is known to cause lung metastasis. The answer is Wilms tumor. Okay, the answer is Wilms tumor. Okay, so hemosidrosis, beta, what I was telling you was, अगर मिट्रल स्टेनोसिस है किसी को तो पल्मोनरी वेनस हाइपरटेंशन होगा, पल्मोनरी वेन में प्रेशर ज्यादा होगा, उस कारण से कैपिलरीज में से हीमोसिड्रिन को लीक होगा और वहां हीमोसिड्रिन लेडन मैक्रोफाजेस आके हीमोसिड्रिन नोड्यूल्स बना देंगे. सो वी कॉल इट हीमोसिड्रोसिस. Okay, everybody clear? Okay, are you clear with this much? So what we have seen today is, we have seen Millery appearance, we have seen the cannonball appearance. Both can be seen in metastasis. There is no hard and fast rule. Now, another question I want you to see with me is, let's see if you are able to answer. Suppose this is a branch of a tree. Suppose this is a branch of a tree. You need to tell me why there are no leaves on this tree. अगर ये कोई ट्री की ब्रांच है तो कोई लीफ क्यों नहीं है? Probably it is a winter season going on in the western countries. विंटर में वहां पे सारी लीव्स गिर जाती है. Okay, now tell me, what season comes after winter? What season comes after winter? That is spring. Spring में क्या होगा? Spring में the tree will start to bud. The tree will start to bud and you will start seeing small leaves coming out of these branches. This is called as tree in bud. I can see all of you know the seasons very well. That is good. So in the spring season, the trees start to bud and the hope comes back after a cold, gloomy, dark winter. That is why a lot of English poetry is done in spring season, because that change in season is what that inspires the poets. Now I want you to see the CT scan again. In these lungs, this is how the normal bronchovascular marking should look like. Okay, this is how the normal dividing, bronchovascular marking should look like. Now look on the other side. You will be able to appreciate that along the branching bronchovascular bundle, we can see some nodules in branching pattern. This appearance on a CT scan rightly has been called by the medicine doctors who see poetry in it, they call it as tree in bud sign. This is called as tree in bud sign. Everybody understands? So this is where, the children sometimes get confused. In the exam, they will say, in which condition do we see tree in bud sign? Tree in bud sign means that the nodules are seen in a branching pattern around the bronchovascular bundle. It is seen if you have endobronchial spread of infection, specifically or commonly in tuberculosis. Everybody understands? Everybody understands? Are you clear? Are you clear or not? So please see an answer. TB, if you have hematogenous spread, we have miliary appearance. But if you have endobronchial spread, the name is tree in bud sign. Tree in bud sign is seen in endobronchial spread of TB. So we see the origin of the word and why we are calling this word as like this. Okay. Before I go on, I also want you to appreciate one or two more findings. Listen to me, everybody. Compare the hilum on the right side to the hilum on the left side. The right hilum is definitely enlarged. This patient has a hilar lymph node enlargement, unilateral. What is the possible cause? What do you think is the most important cause of unilateral hilar lymphadenopathy? What is the most important cause of unilateral hilar lymphadenopathy? So the most important cause of hilar lymphadenopathy is tuberculosis. Primary or secondary? Primary TB. So lymphadenopathy is a feature of primary tuberculosis, not seen in secondary TB. It's mostly in primary. Now tell me, a patient with AIDS develops tuberculosis, X-ray chest will show cavitation. True or false? Lymphadenopathy. True or false? Okay. Resembles primary infection. True or false? So remember, in AIDS, cavitation is not seen because cavitation needs an immune response. But lymphadenopathy would be seen because it is seen in primary infection, and in AIDS, because you don't have an immune response to the organism, the infection resembles primary infection. So the answer is, this is false, this is true, this is true. Everybody gets it? Very good. Most of you are able to get it right. AIDS patient, if they develop TB, will not have cavitation, but will have lymphadenopathy, will have appearance similar to primary infection. Okay. Tree in bud on a CT scan is a sign of active endobronchial spread of tuberculosis. है ना? ट्री इन बर्ड साइन था एक्टिव एंडोब्रोंकियल टीबी के अंदर. जब टीबी ब्रोंकस के अंदर फैल रही है तो ऐसा देखने को मिलेगा, और ब्लड में फैल रही है तो मिलरी मिलेगा. ओके, बट वेयर स्टूडेंट्स विल गेट कंफ्यूज्ड इज दिस एक्सरे. लेट्स सी हाउ मेनी ऑफ यू कैन आंसर. lymph node, bilateral, symmetric, hilar lymphadenopathy. Bilaterally symmetric hilar lymphadenopathy. What do you think is the answer? Now we will not think of tuberculosis, because symmetry, as a word, symmetry does not go with infections or neoplasms. भाई टीबी क्यों सिमेट्रिक होगी, नियोप्लाज्म क्यों सिमेट्रिक होगा? Here this must be a systemic disorder like sarcoidosis. So if they say bilateral symmetric hilar lymphadenopathy in the picture, then you think of sarcoidosis. Any one of you can answer, beta, hai na? Any one of you can answer. Okay. Sarcoidosis, the angiotensin converting enzyme levels in the patient's serum will be high, calcium high. So they will always make a clinical question by saying ACE levels are raised, there is hypercalcemia. Okay, this is how it would frame like. Now in sarcoid, 3 lymph nodes enlargement is typical. On a X-ray, it is classic to see enlargement of these 3 lymph nodes in sarcoid. Which 3 lymph nodes will be there? Right paratracheal and bilateral hilar. These 3 lymph nodes, if they are enlarged, are considered very typical of sarcoidosis. Which 3? Right paratracheal and bilateral hilar lymph nodes. Okay? Everybody clear? Okay. Now the question is, let's see if you can answer. This chest X-ray sign is called as 1, 2, 3 sign. Also called as, now imagine everybody, if suppose somebody from outside comes to your home, to welcome that person, you will, welcome him with a garland. So this is a garland of lymph nodes. So we call it as garland sign. Name 2 chest X-ray signs of sarcoidosis. 1, 2, 3 sign, garland sign. 1, 2, 3 sign, garland sign. Okay, everybody clear? Okay, very important. Another thing to remember is, okay, there is an isotope called as gallium-67. This isotope has affinity to inflammation and to sarcoid tissue. There is an isotope called as gallium. Okay. Okay, remember there is an isotope called as gallium which has affinity to inflammation and sarcoid tissue. Now let's see if you can answer, beta. Let's see if you can answer. This gallium in a normal person is taken up by only by his nasopharynx. In a normal person, okay, in a normal person, gallium is taken up by nasopharynx, probably because of the lymphoid tissue that you have in the Waldeur's ring. It is taken up by the normally by a nasopharynx. In sarcoidosis, it is taken up by the glands also, like the lacrimal glands and the parotid glands. So when you look at this gallium scan, you will see physiological uptake in the center because of the nose and the nasopharynx taking it up. Okay. Plus you will see uptake bilaterally symmetrical in the lacrimal glands and bilaterally in the parotid glands. Okay. Any resemblance to somebody that we have seen before? This is called as the panda sign. So can you tell me panda sign on panda sign on gallium-67 scan is seen in sarcoidosis. Now without changing the pages of your notebook, बिना कॉपी के पेज पलटे बताना है फेस ऑफ जाइंट पांडा ऑन एमआरआई ब्रेन कहां पे सिखाया था मैंने फेस ऑफ पांडा ऑन एमआरआई ब्रेन कहां बताया मैंने सो फेस ऑफ पांडा ऑन एमआरआई ब्रेन वाज विल्सन्स डिजीज आर यू क्लियर कई बच्चे उल्टा कर देते हैं पेपर में पूछा ब्रेन में होता है मार्क कर देते हैं सार्कोइड फिर वापस आते हैं कहते हैं पता नहीं सर रैंक क्यों नहीं आ रहा है ना सो डू यू अंडरस्टैंड दिस और नॉट सो वो ऐसे वाले बच्चे ऐसे याद करते पांडा सार्कोइड एग्जाम कहता बता ब्रेन में पांडा है क्या आंसर है सार्कोइड गलत हो गया यू अंडरस्टैंड दिस और नॉट सो वी आर नॉट सपोज टू मग इट अप दैट इज व्हाई आई एम स्पेंडिंग टाइम so that we don't miss it in the exam. Similarly, in the chest, gallium uptake will be seen in the right paratracheal node, right hilar node, left hilar node, beta. That is called as lambda sign after the Greek letter lambda. Are you aware of this? So lambda sign also in the chest on a gallium scan is a sign of sarcoid. So in sarcoidosis there are two signs. Panda sign, lambda sign. Panda in face, lambda in chest. Panda sign, lambda sign seen in, tell me, sarcoidosis. Okay. Now, if I ask you a question now, have you heard of a disease called as silicosis? Have you heard of, have you heard of a disease called as silicosis? Okay, listen to me बच्चे सुनो मेरे साथ सुनो okay देखो बेटा देखो okay suppose मेरे हाथ में ना सिलिका है okay we're doing some magic in the night okay magic मेरे हाथ में सिलिका है so in my hand I have silica and I throw it up what will happen tell me what will happen silica will float in the air because it is very lightweight. It is a very light particle like dust. It floats. So when it floats in the lungs, it floats to the upper lobes. Will you remember? Silicosis is an upper lobe predominant disorder. It is seen in the upper lobe of the lung. Now let's see if you can answer. The silica which goes to the upper lobe of your lung now is taken up by the macrophages. जो macrophage हैं, they will tend to eat up the silica. Macrophages will eat the silica. Okay. And then, listen to me, these macrophages which are silica laden will go via the lymphatics into the lymph nodes. But silica is a poison to the macrophages. Silica is a poison to the macrophages. So macrophages, they tend to die in the lymphatics, in the lymph nodes, and the lymph nodes become calcified. And that is why you might have read about eggshell calcification seen in both silicosis as well as sarcoidosis, like some of you were mentioning. But if they both are given in choice, the single best answer is silicosis. Are you clear? Eggshell calcification of the hilar nodes. Everybody understands? Okay, second question. Let's see if you can answer. What will happen to the upper lobe lymphatic channels in silicosis? The lymphatics will become blocked. Because of the macrophages laden with silica and they die into the lymphatics, they cause the lymphatic channels to be blocked. Okay. Now, can you name an infection, a common infection in mine workers as well as other people with lower socioeconomic status, which you typically see in the upper lobe? That is tuberculosis. Now, these people, because of their poor socioeconomic status, tend to develop tuberculosis. But the problem is the upper lobe, the lymphatic channels are already fibrosed. So the tubercular bacilli cannot be cleared and they become more prone to develop tuberculosis. Have you heard of this before? So which infection is commonly seen in patients with silicosis? Tuberculosis. Clear? This is because of dual reasoning of lower socioeconomic status as well as upper lobe lymphatics getting compromised. Second thing to remember here is upper lobe predominance. Third is eggshell calcification. Okay, now see. So when we look at the exam on an X-ray, this is how the X-ray would look like. You will see opacities in the upper lobe. So bilateral upper lobe, you will see some opacity, some fibrosis, and then you will see a lot of high density white calcified lymph nodes in the hilum. Okay, so this is when you think of silicosis in occupational lung diseases. Okay, Kinnal beta, are you clear? Lambda sign was on gallium scan. 1, 2, 3 sign was on chest X-ray. Okay, some of you are again saying why TB? बेटा जो गोल माइन में काम कर रहा है, सैंड माइन में काम कर रहा है, वो गरीब आदमी है, उसको पहले से ही उसको रिस्क में ज्यादा है कि क्राउडिंग वगैरह के कारण टीबी होने का, ऊपर से उसके अपर लोब के लिम्फेटिक्स खराब हो गए सिलिका लेडन मैक्रोफाजेस से, and that is why they tend to develop more chances of developing tuberculosis. Okay, yes, and eggshell calcification I just mentioned, beta, is seen in both silicosis and sarcoidosis, but if one is to be marked in the exam, silicosis is the best answer to be marked. दोनों सही है, एक लगाना है तो ये मार्क करना चाहिए. Okay, so I said which infection due to lymphatics getting blocked is seen in silicosis? The answer is tuberculosis. Yes, macrophages function gets affected in silicosis. That is correct. Now, once you're clear, let's answer another question. The reverse of silicosis that we all study in our pathology is asbestosis. Okay, reverse of silicosis is asbestosis. Okay, beta. Now see, look at me, beta. Suppose, देखो बेटा, मेरे हाथ में I have asbestos. Oh, it is so heavy. Oh, it's going down. So what should I mark? The answer is lower lobe predominance. The answer is lower lobe predominance. Are you clear or not? Silicosis कहाँ पे था? Upper lobe. Asbestos कहाँ होगा? Lower lobe. Now, but the typical feature of asbestosis is pleural involvement. Asbestosis में प्लूरा भी इन्वॉल्व होगी जो कि सिलिकोसिस में नहीं होती. Clear? So asbestosis में you will have lower lobe involvement, you will have pleural involvement. अच्छा, धीरे धीरे जा रहे हैं बेटा, धीरे धीरे पढ़ा रहा हूं, बिल्कुल धीरे धीरे. ओके निशा, डोंट वरी. ओके, slowly. Pleural involvement is seen in asbestosis. Now tell me बेटा, tell me, ठीक है, प्लूरा में कोई बाहर से चीज आ गई, so it will lead to Inflammation. Okay. Now, if you have plural inflammation, what will happen in inflammation? The capillaries will be leaky. कैपिलरी लीक करेंगी तो प्लूरा में क्या होगा? Effusion. So can you have pleural effusion in asbestosis? Yes. Then chronic inflammation होगी तो क्या होगा? Fibrosis. Can you have fibrotic plaques in asbestosis? Yes. And later on you can have calcified plaques. You can also have pleural calcification. And if some of you can answer, बेटा देखो, सोचो, एस्बेस्टोस आने से वहां इन्फ्लामेशन हुई, but asbestos can also act like a carcinogen. So then it can even lead to a malignancy developing there. That is pleural mesothelioma भी हो सकते हैं. Clear or not? So remember, okay, everybody clear or not? बच्चे बताएं, are you clear? Pleural effusion, pleural fibrosis, pleural calcification, pleural malignancy. The key word is pleural. All are associated with asbestosis. Very good. Now see if you can answer. Now I want you to look at this X-ray and tell me what are you able to see in this X-ray. In this X-ray, we are able to see calcification. कहाँ है calcification? ये रही, इधर भी है. Okay, we are able to see multiple areas of calcification. Okay, clear? Now see an answer. Now suppose I take a paper. Okay, I don't know I have it or not. Okay, it might be a Deepti's class paper, but let's see if try. So if I have a paper and I do it like this. Okay, उसी तरह से when the pleura gets fibrosed and calcify, it contracts. You agree? Pleura fibrose हो गई, calcify हो गई, it will be like this. So what happens is when there is pleural calcification, it looks like it has undulating margins. It looks like these leaves that you might have seen in the Christmas tree with undulating margins. Okay, so maybe you're not feeling like a Christmas tree, so I'm keeping a gift for you, बस. अब ठीक है? So now it looks like a Christmas tree to you. Gift भी है यहाँ पे. Okay, so now these leaves are called as holly leaves, and the appearance that we saw on the X-ray is called as holly leaf sign of asbestosis. Are you clear? Are you clear? Everybody understands? Holly leaf sign on chest X-ray seen in asbestosis. Everybody clear? Okay. So, अच्छा बताओ. Okay. Are you clear बच्चे? अच्छा बताओ. कौन लाता है गिफ्ट बेटा? कौन लाता है क्रिसमस में गिफ्ट बेटा? Anyone? है ना? लाते मम्मी पापा बेटा, शाबाश. कोई सेंटा क्लॉज नहीं लाता बेटा, मम्मी पापा लेके आते हैं. घर जाएंगे सुबह पे बात करेंगे मम्मी पापा से. ओके, इट्स ऑलवेज मम्मी पापा हु गेट्स यू द गिफ्ट, नॉट द सेंटा क्लॉज. बच्चे तो नहीं सोचते ऐसा ना. ओके, वेरी गुड. नाउ सी एन आंसर बेटा. सो व्हाट वी लर्नड इन दिस फ्लैश कार्ड वाज, in this flashcard we learned the radiological differences between silicosis and asbestosis. In this flashcard we learned the X-ray differences between silicosis and sarcoidosis. Now we come to the last part of the class. Okay, अब और लीफ नहीं लेके आएंगे बेटा. Okay, we come to the last part of the class. Last part of the class is I just want to show you how to see the anatomy of the chest on a CT scan. Okay. Last part. Okay. The last part of the class finally is there. Okay. I want to show you how to look at the chest structures on a CT scan. Okay. Let's see one by one. Okay. One by one देखते हैं बेटा. बेटे जब प्लूरा में कोई चीज इन्फ्लामेशन कर सकती है, अगर वही चीज कार्सिनोजेन भी है तो ट्यूमर भी करेगी. सो दैट इज व्हाई एस्बेस्टोस में प्लूरल प्लाक्स भी होते हैं, प्लूरल मेसोथेलियोमा भी हो सकते हैं. ओके, आर यू क्लियर बेटा? नाउ लेट्स सी इफ यू कैन आंसर बेटा. ओके एवरीबॉडी, एवरीबॉडी बच्चे देखो, राइट साइड, लेफ्ट साइड, एंटीरियर, पोस्टीरियर. बस बेटा बस, हम एंड पे आ गए क्लास के. ओके, सो वी आर एबल टू सी एवरीबॉडी right side, left side. Okay, everybody now tell me. So once you are able to see with me that this is your sternum, anteriorly placed sternum, posteriorly you have vertebra. Just behind the sternum we have two veins. Just behind the sternum you have two veins, right brachiocephalic vein, left brachiocephalic vein. Clear? Everybody understands? Just behind the sternum. How to identify? I'm teaching you. Sternum देखो, उसके एकदम पीछे दो vein दिखेंगी in the superior mediastinum. One is your right brachiocephalic vein, other is left brachiocephalic vein. The left vein is longer and it crosses behind the sternum to go towards the right side. Left की vein लंबी है, वो crossover कर रही है. So can you see the right brachiocephalic vein? Okay, and the left brachiocephalic vein. Just behind the veins, you have three arteries. The first artery that you see here is brachiocephalic artery. Second is left common carotid. Third is left subclavian artery. What you see in the center as T is trachea. Behind the trachea, you can see a small muscular tube called as the esophagus. Okay, very important. Nobody should do it wrong in the exam. Now what happens is कि आप हमेशा चाहते हो कि बीमारी देखें, एबनॉर्मल देखें, और मैं हमेशा आपको वापस नॉर्मल एनाटॉमी पे ले आऊंगा, बिकॉज आई वांट यू टू फर्स्ट अंडरस्टैंड वेयर इज द नॉर्मल स्ट्रक्चर्स प्रेजेंट. Otherwise, you will not be able to do it in the exam. So we will revise it together, beta. Okay, we will revise it together. आप लोग बताना, मैं mark करूंगा, आप बोलते जाना. Okay. So let's see how many of you can answer the question. Identify the structure marked with the arrow. Identify the structure marked with the arrow. This must be the right brachiocephalic vein. इसको brachiocephalic को inanimate भी कहते हैं, inanimate भी. Identify the structure marked with the arrow. That is your left brachiocephalic vein. Okay. Identify the structure marked with the arrow. Brachiocephalic or inanimate artery. Structure marked with the arrow. Left common carotid. Structure marked with the arrow. Left subclavian. Trachea, esophagus. Okay, everybody able to do this? That is the superior mediastinum that I wanted you to identify. Now, are you wanting to do a AIMS level question? Okay. So now I will give you a AIMS level integrated MCQ to solve. A patient has 4 branches from arch of aorta, and the 4th branch is seen on a CT behind the esophagus. What could this be? Let us look at, और अगर आप अब थकने के बाद भी सोच पाओगे तो हमेशा जीतोगे. Remember, students who are able to think even when they are tired, they are able to think and enjoy, they always win. आपने अपने fatigue को, अपनी थकान को सपनों से बड़ा नहीं बना देना, है ना. सपना ज्यादा बड़ा है. Okay, so अगर मैं अभी भी सोच पा रहा हूं, we will be able to win. So now remember, normally from arch of aorta you should have 3 branches. If there is a 4th branch coming, that must be an aberrant vessel. So in some patients you have an aberrant right subclavian artery which arises as a 4th branch from arch of aorta and goes posterior to the esophagus towards the right side and causes dysphagia. This is called as dysphagia lusoria. This is called as dysphagia lusoria. But the key is, अगर normal ही नहीं बताऊंगा तो कैसे बताओगे abnormal? So normally you should have only 3 vessels arising from arch of aorta. अगर 4 आ गई तो esophagus के पीछे 4th branch है तो that is aberrant right subclavian artery. Very good. I can see all of you has studied in surgery and anatomy both. Now we are able to put them together. Okay, let's go further. Now, when I go down, we were going from the superior section of the mediastinum. Now we are going downwards. Then you will see a very large vessel, which is called as the arch of aorta. Okay, jago beta. Can you see the arch of aorta now? Okay. Now let us understand, adjoining the arch of aorta, you have a vein called as superior vena cava. So adjoining the arch of aorta, you can see the superior vena cava. दोनों तरफ की brachiocephalic, both the brachiocephalic have joined to form the superior vena cava. Are you clear? And you can see the trachea. In a child, remember, in a child, between the sternum and the great vessels, you have a triangular gland like this. बच्चे में यहां पे anteriorly एक triangular gland होता है. Can you think of it and tell me which one? Can you name a triangular gland which is between the sternum and the arch of aorta? Okay, उसका क्या नाम है? उसका नाम होता है thymus. This is where thymus should be. This is the location of thymus. Okay. Okay, everybody now. Let's see if you can answer. Okay. Let's see आप में से कौन बताता है. बेटा सोच के बताना है, ठीक है? A patient has myasthenia gravis. A patient has myasthenia gravis. Okay. And his CT scan shows a tumor here. ये क्या हो सकता है? So if you have myasthenia gravis and you see a tumor in the anterior mediastinum behind the sternum, you think of thymoma. You think of thymoma. Are you clear? Are you clear? Okay. Can you name a film star who had thymoma and myasthenia gravis? Thymoma and myasthenia gravis? Okay, हाँ जी, अभी थोड़ा सा लाइट नहीं है लेकिन मैं थोड़ा सा कोशिश कर रहा हूँ कि to get back with my phone internet. just a power failure actually. Morning se actually we had put on the generator, so now the generator light has gone. Okay, so let's see. Okay, so myasthenia gravis and thymoma, the combination was present in Amitabh Bachchan. Okay, Amitabh Bachchan. Now let's see if you can answer. Okay, okay, let's see. So now when you go down, okay, beta, ध्यान से देख लो. When you go down, now you can see ascending aorta anteriorly, descending aorta posteriorly. Okay, now you can see ascending aorta anteriorly, descending aorta posteriorly. ऐसे पहचानना है हमेशा. वर्टेब्रा के साथ में जो है वो डिसेंडिंग एओर्टा है, जो आगे है वो असेंडिंग एओर्टा है. देन यू विल नेवर डू इट रॉन्ग. आर यू क्लियर? Ascending aorta anteriorly, descending aorta posteriorly. Along with ascending aorta, you have superior vena cava. Ascending aorta के साथ में superior vena cava है. सबका बर्थडे रात को हो जाता है ना. Ascending aorta के साथ में you have superior vena cava. Okay. Behind it, the larger air tube is trachea. The smaller air tube is esophagus. Internet आएगा ना बता रही. Okay, so the smaller air tube is the esophagus. Right next to the trachea, you can see a vein which is going from behind, going anteriorly towards the SVC. That is your azygous vein. That is your azygous vein. Are you clear? Will you be able to identify? पहचान जाएंगे बच्चे सारे. देखो आगे की तरफ ascending aorta है, पीछे descending aorta है. Right next to ascending aorta, you have the superior vena cava, and then you have the azygous vein. Another thing to understand here is, okay, this is left pulmonary artery. We can start seeing the left pulmonary artery before we see the right, because the left branch arises higher than the right. So we can see the left pulmonary artery already. Okay? Okay, beta. Okay. बस ये खत्म करना है बेटा, बस ये 4 इमेज खत्म करनी है, then we will go home. Okay? Now, then when we, okay, esophagus is a air-filled muscular tube, beta, है ना? Now when we go down further, again the aorta right next to the vertebra is descending aorta, anteriorly placed ascending aorta. This is your main pulmonary artery, shaped like an inverted Y, dividing into right and left branch. Okay? And right next to the ascending aorta, the trachea will no longer be seen. Instead of trachea, you will see right and left bronchi, and behind them you will see the esophagus. Okay, everybody, बस बेटा बस ये खत्म करना है बेटा, ऐसे बेहोश नहीं होना बेटा, जागृति नहीं ऐसे नहीं करना. ओके बच्चे बस मजे कर रहे हैं, एंजॉय कर रहे हैं, कुछ नहीं है ना. सो यू कैन सी द असेंडिंग एओर्टा, डिसेंडिंग एओर्टा. बेटा बताना कौन सा एओर्टा पीछे को होगा, डिसेंडिंग एओर्टा आगे होगा, असेंडिंग एओर्टा. ओके, एंड वी कैन सी द वाई, उल्टे वाई जैसा स्ट्रक्चर, रिवर्स उल्टा वाई जैसा, ये पल्मोनरी आर्टरी, एंड एओर्टा के साथ में सुपीरियर वेना कावा है. Okay, every time they will ask you to identify normal structures, and many students get them wrong on a CT क्योंकि उन्हें anatomy तो पता होती है, बट सीटी नहीं पता होता. बस बस हम वी आर अबाउट टू फिनिश. ओके, वी आर अबाउट टू फिनिश, है ना, बस आगे. एक सेकंड. अभी वो दीप्ति भी बोल रही है अभी क्लास जल्दी खत्म करो. मैं कहा अभी तेरी बारे में तो मैंने नहीं बोला था. मेरी बारी में ऐसा है ना. ओके, बस बस खत्म कर रहे बेटा. वो लाइट चली गई ना, इसलिए 2 मिनट एक्स्ट्रा लग गए. ओके. Okay, but we are about to see the end of it. Don't worry. So similarly, now when you go down, anteriorly ascending aorta with the vertebra, descending aorta, and you have the superior vena cava. This is your main pulmonary artery continuing as the right branch. So you can notice the left branch, बस बेटा बस, left branch पहले शुरू हुई थी और राइट बाद में शुरू हो रही है. सो दिस इज हाउ. सो एनाटॉमिकली लेफ्ट पल्मोनरी आर्टरी अराइजेस हायर देन दी राइट. Okay, now we are about to finish it beta. We are about to finish it. Now when you go down, you can see the descending aorta right next to the vertebra, and the ascending aorta looks dilated now because this is the aortic root. From the aortic root, actually speaking, you have the coronary artery arising, and this is your right ventricular outflow tract, RVO. This is from where the pulmonary artery is going to arise. Next to the aortic root, you have the superior vena cava. This is the place where superior vena cava is joining the right atrium. From this place, a tubular outpouching goes anterior to the aortic root. This is called as right auricle. At this level, you can see superior pulmonary veins opening into the left atrium, and a tubular outpouching arises from the left atrium at this level, which is called as left auricle. बच्चे रुक जाओ भाई, टाइप ना करो. खत्म करने तो 2 सेक्शन है सिर्फ. सिर्फ 2 है बेटा, सिर्फ 2 है, इसमें कुछ भी नहीं. ओके, नाउ अगेन सी विद मी बेटा. देख लो देख लो. आरवीओ मतलब राइट वेंट्रिकुलर आउटफ्लो ट्रैक्ट. ये अयोटिक रूट था, ये सुपीरियर वेना कावा, ये राइट ऑरिकल, ये लेफ्ट ऑरिकल, ये सुपीरियर पल्मोनरी वेन्स दोनों तरफ की, ये डिसेंडिंग एओर्टा. ओके, फाइनल फाइनल पे आ गए, एंड पे आ गए बस. सो दिस इज द एंड नाउ. This is right next to your vertebra. You have descending aorta. The posterior most chamber of the heart is left atrium. These are your inferior pulmonary veins. The dilated part in the center is aortic root. Chamber on the right side is right atrium. And right next to the aortic root, you have the right ventricular outflow tract. Okay. And finally, the cardiac chamber with the thickest wall is LV. Anterior most is RV. Posterior most is left atrium. Along the vertebra, you have descending aorta. Towards the right, you have right atrium. SPV था बेटा सुपीरियर पल्मोनरी वेन, IPV था इंफीरियर पल्मोनरी वेन. जो 4 पल्मोनरी वेन होती है ना वो. ओके बस बेटा बस वी जस्ट नीड टू फिनिश देम एंड देन विल बी गोइंग इट है ना. सो दैट हाइपरडेंस दैट इज द केवो एट्रियल जंक्शन बेटा जो आप पूछ रहे थे ना. ये केवो एट्रियल जंक्शन है जहां पे एसवीसी राइट एट्रियम में जा रहा है. ओके बेटा मैं अभी रिवाइज दोबारा रिपीट कर दूंगा. डोंट वरी. अगली बार आई विल रिपीट इट. डोंट वरी. ओके okay. So I hope you understood the game. I'll just discuss it once to give you a summary. ये sternum है, ये vertebra है. So this is what we saw. We saw the heart oriented like this, and we saw the ascending aorta, descending aorta, arch of aorta, and the branches. Okay. So initial sections यहाँ से लिए हुए थे जहां पे vessels दिख रही थी, फिर arch of aorta दिखा, फिर pulmonary artery ascending descending दिख रहे थे, फिर cardiac chamber दिख रहे थे. Okay. Everybody clear? So what we'll do is we will continue from this point onwards. I'll revise this again, the chest anatomy once more again in the next class, and quickly recap it, and then we'll move forward. After this, we'll do the cardiac diseases on radiology. Okay. Thank you very much. Before I send you home today, I have a final message to give, and that final message is, बेटा क्या है वो मेरा message is that it is important कि हमेशा थकेंगे. हर कोई थकता है बेटा, लेकिन people who get massively successful are people who work despite being tired. है ना. थकने भाई सपने को, आपके सपनों को आपकी थकान नहीं पता है ना. और उनको रोज आगे बढ़ना है. जिस दिन थके हुए हैं उस दिन भी आगे बढ़ना है. ओके, दैट शुड बी योर स्पिरिट. जिस दिन थके हुए हैं उस दिन भी आगे बढ़ना है. I wish you all the best. So my message for the day is very, very important. Please don't let fatigue overpower you. है ना. आपके सपनों को आप थकान से नहीं हरा सकते. That is my message for the day. Thank you very much.
And all of you are very nice kids. आज बहुत मेहनत कर रहे हो है ना. And I wish God आप सबको बहुत सारा success दे for all the efforts that you children are putting in to become better doctors. And I'm so happy that India is going to get such wonderful, wonderful doctors who are working so hard. Okay, आपकी मेहनत देखकर I think today I am feeling very overwhelmed. Right, so God bless you all with a lot of strength, with a lot of positivity, and keep smiling all of you. ये सिर्फ पढ़ाई है, हो जाएगी. ओके
बेटा हंसते खेलते निपटा लेंगे, घबराए नहीं है ना. लेट्स स्टे पॉजिटिव, मेहनत करेंगे, सब कुछ कर पाएंगे. स्टे पॉजिटिव एंड बोलना नहीं है 50 MCQ रोज करने. गॉड ब्लेस यू, बेस्ट ऑफ लक. इट्स अ प्लेजर. बाय 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 बच्चों, बाय बाय.